Hello everyone, welcome to another episode of Next Saviours Essential Question Series for NEET PG 2025, where we are talking about the step-by-step guidance in the management of diabetic ketoacidosis. Now, so without wasting any time further, all of you know that even in this examination also, there is going to be a question on DKA and how the language of the questions are given. Like 35-year-old male with a history of type 1 diabetes mellitus presenting to the emergency with the nausea, vomiting, and abdominal pain, increasing fatigue for the past 2 days. There is a report of polyuria, polydipsia, and unintentional weight loss over the past week. His family states that he has altered mental status and deep labored breathing for the last several hours. Now, on physical examination, the patient appears dehydrated with a dry mucous membrane, with the heart rate of 120, with the blood pressure of 90 by 60. Respiratory rate is increased, and he demonstrates deep, rapid, labored respiration with no pauses in between inhalation and exhalation. So, this is how the Kussmaul's breathings are identified. Fruity odor is detected in his breath. So, these are the clinical features. So, initial laboratory investigations are the blood glucose, which is more than 250. Arterial blood gas analysis shows the pH low, bicarbonates low, partial pressure of carbon dioxide is also low, so it is suggestive of metabolic acidosis with respiratory compensation. Now, serum ketones are positive, serum sodium is 135, potassium is low, anion gap is high, and the urine analysis shows positive for the glucose and ketones. So this is the language of the question, on the basis of which you will be asked that what is the management, which of the following is the most appropriate next step in the management of this patient. When you are presented with such a question, first of all you have to identify that what you are dealing with. As you know, in the clinical feature there are the features of polyuria, polydipsia, weight loss, which is because of the osmotic diuresis present. The features of dehydration like dry mucosa, sunken eyes present in the question. Nausea, vomiting, abdominal pain is because of the acidosis, the altered sensorium, which might be ranging from the confusion to coma. The features of the Kussmaul breathings are provided. The fruity odor in the breath is provided. Tachycardia and hypotension, which is because of the hypovolemia due to dehydration, is provided. So when you see these clinical features, one thing is for sure that you are dealing with the question of diabetic ketoacidosis. And in the examination hall itself, your immediate goal is to identify that what is the category of diabetic ketoacidosis. That means, is it mild, moderate, or severe? Because it will help you out in the management decisions. If the arterial pH is less than 7, it is severe. Another thing is the bicarbonate levels, which is less than 10, is severe. If the anion gap is more than 12, it is severe. But if it is more than 10, that means in ranging between 10 to 12, it is mild. And the altered mental status. That means if the patient is in stupor or coma, it is severe. If the patient is drowsy, it is moderate. If the patient is alert, it is mild kind of the DKA. After identifying that what is the category of the diabetic ketoacidosis, the second thing that you have to look for is the potassium levels which are provided in the question. And the third, obviously, is the bicarbonate level. So let's start with the management. Like, first thing that you have to go is the fluid replacement for rehydration. And the goal is to restore the intravascular volume, improve the renal perfusion, and facilitate the glucose clearance. If the patient is suffering from mild DKA, diabetic ketoacidosis, then zero point 0.9 of the normal saline at 500 ml per hour for the first 2 hours. This is how you have to initiate it with. For moderate, it has to be 0.9% NS in the first hour, and then continue with 250 to 500 ml per hour. And for the severe diabetic ketoacidosis, it has to be 1 to 1.5 liter of 0.9% NS over the first hour, and then 500 ml per hour. Now, what are the checkpoints? If serum sodium is high, then switch to 0.45% NS after initial bolus. And when the glucose falls to less than 250 milligram per deciliter, then switch to D5 in order to prevent the hypoglycemia. The second is the insulin therapy. The goal is to reduce the blood glucose levels, but gradually. Why? In order to prevent the precipitation of the complications related to rapid decline in the blood glucose levels, and to suppress the ketogenesis. So how is it achieved? By the infusion of zero point 0.1 units per kg per hour IV, that is intravenous infusion. Now, how to continue with the follow-up? Like, if the glucose starts falling, and that starts falling in the category of 50 to 70 milligram per deciliter per hour, then maintain the same infusion rate. And once the glucose is less than 250 milligram per deciliter, then switch to D5 and continue insulin at the rate of zero point 0.5 in units per kg per hour. And you have to monitor every 1 to 2 hours. Now, one thing that you might be thinking of, that why is this bolus avoided? Now, the reason is simple, that it avoids rapid glucose drop, which may cause cerebral edema, and also it might precipitate hypokalemia because insulin is responsible for shifting the potassium into the cells. But in some of the exceptional cases, the IV bolus might also be required, like severe diabetic ketoacidosis with significant insulin resistance, like morbid obesity, high insulin requirements in the previous admissions. Now, another thing that you might be thinking is that when to stop this IV insulin and switch to the subcutaneous insulin. And just for that, you have to remember that diabetic ketoacidosis resolution criteria, which includes the glucose level of less than 200 milligram per deciliter, the bicarbonates more than 18 milliequivalent per liter, the pH more than 7.3, and the anion gap of less than or equal to 12. So the next very important category is the potassium replacement. The goal is to prevent the life-threatening arrhythmias due to total body potassium depletion, and you have to monitor it every 2 to 4 hours. Now, how the serum potassium levels are important, because you remember that when I told you that once you identify the question, then immediately you have to look for the serum potassium levels related to diabetic ketoacidosis. If the serum potassium levels are more than 5.3 milliequivalent per liter, then no replacement is required. All you have to do is monitoring. But if the serum potassium level lies in between 3.3 and 5.3, then start the replacement therapy. And remember, the most importantly is when the potassium levels are less than 3.3 milliequivalent per liter, then hold insulin, because insulin is responsible for stimulating the sodium potassium ATPase, which is responsible for driving the potassium into the cell. So it further causes a drop in the serum potassium level. Potassium level becomes more than 3.3 milliequivalent per liter, you have to hold the insulin. This is one checkpoint which is extremely important for you to remember. Bicarbonate therapy, but it is only reserved for the severe acidosis where the indication is pH values are less than 6.9. Now, phosphate replacement might also be required, but only again in severe deficiency, and where you have to replace if the values are too low, like less than 1 milligram per deciliter, or respiratory muscles are found to be weakened. And finally, you have to identify and treat the underlying causes. Some of the drugs like SGL2 inhibitors might be responsible for precipitating the diabetic ketoacidosis. Other of the causes you already are aware of, and you have to manage them accordingly. So now let's read the question again, because we have learned about the management also after identifying the disease. So in this question, based on the laboratory investigation findings, you came to know that the patient is obviously suffering from the moderate to severe diabetic ketoacidosis. And if you look at the management options, then the first option provided over here is the replacement of the potassium first without insulin. Now, there is a specific indication when not to give insulin when the potassium levels are less than 3.3 milliequivalent. But here in the question, it is 4.3. So this option is obviously wrong. Now, as far as the option B is concerned, we came to understand that the first line management of diabetic ketoacidosis, it involves the aggressive fluid resuscitation with normal saline and IV insulin infusion to reduce the blood glucose and suppress ketogenesis. So this option seems correct, but before marking the answer, you have to rule out the other options too. Like bicarbonate therapy is not needed until the pH is less than 6.9. This is what we have learned. And here they are asking immediately to give intravenous bicarbonate. So this obviously is not the correct answer. And finally, administer subcutaneous insulin and discharge the patient with an outpatient follow-up. No, because subcutaneous insulin is not appropriate for moderate to severe diabetic ketoacidosis, with which the patient is suffering from in this particular question, and the patient should not be discharged immediately. So this also is the incorrect answer. So the correct answer for this question is option number B. Hope you have understood that how to identify the question on diabetic ketoacidosis. What are the key points that you have to take from the question, like levels of the potassium, the pH for the categorization, the resolution criteria, and then you have to progress to mark the answer for this particular one. So thank you very much. Hope you have understood the session. Please join our Telegram group. The link is provided in the description in order not to miss any update.